Assalamu alaikum everyone. Our next topic of discussion from first aid renal pathology is nephritic syndrome. In our previous lecture, we discussed about nephrotic syndrome in which there was a damage to podocyte and impaired charge barrier, and there was proteinuria. In nephritic syndrome, what happens is that there is glomerular inflammation which leads to the glomerular basement membrane damage. There is loss of RBCs in the urine, dysmorphic RBCs, and hematuria. We know that there are three components of the filtration barrier. First one, these are the endothelial cells, then there is the basement membrane, and then there are the podocytes. So endothelial cells, what they do is that they act as a barrier for the red blood cells and other cells, and they don't allow them to pass through this barrier. So in nephritic syndrome, this endothelial cells barrier is destroyed due to inflammation of the glomerulus, and they allow the red blood cell to pass into the through this barrier and into the urine. So RBCs in the urine, it is known as hematuria, and the patient will have a cola colored urine, means black urine, due to the RBCs in the urine. So this is the glomerulus, this is the filtration barrier, Bowman's capsule. This is these are the tubules. When RBCs pass through these tubules, here they come into the shape of cast, which are known as RBCs cast. We will see RBC cast into the urine, we will see hematuria, and the shape of the RBCs will be destroyed. We will that is known as dysmorphic RBCs. And when this barrier is destroyed, it will not clean up the nitrogenous waste present in the blood, so their level will increase in the blood urea nitrogen will increase, and it is known as azotemia. When this barrier is not working functional properly, GFR would decrease, there will be decreased glomerular filtration rate, there will be less urine formation, which is known as oliguria. Now less fluid is going into the tubules, less fluid will go into the DCT. We know that in DCT there are macular denser cells which sense the sodium. When they sense less sodium due to less fluid, they will release renin, and we know that renin cause eventually increase in sodium and water retention, which will lead to hypertension. They will also be proteinuria because this barrier is destroyed somewhat, somehow proteins are also released, and the proteinuria is in subnephrotic range, less than 3.5 gram per day, while in nephrotic syndrome it was more than 3.5 grams per day, and in severe cases it may go into the nephrotic range. And these are the examples which we will discuss in detail later on. So there are four important things that we have to remember in nephritic syndrome. First one is the hematuria. There will be RBCs in the urine. Second one is the azotemia, increase in blood urea nitrogen level in the body. Third one is the proteinuria, that is in subnephrotic range with or without edema. And fourth one is the hypertension. These are the four important points of nephritic syndrome, and it occurs due to the inflammation in the glomeruli. Next, we will see examples of nephritic syndrome. First of all, there is infection-related glomerulonephritis. As the name suggests, there is some involvement of infection. What will happen is that there will be any skin or throat infection. The child will present with pharyngitis or skin infections, and after 2 to 4 weeks, that is important, 2 to 4 weeks after pharyngitis or skin infection, the patient or the child will present with symptoms of nephritic syndrome, and it will occur due to group A streptococcal bacteria. And in adults, staphylococcus is the additional causative agent. Now, there is involvement of type 3 hypersensitivity reaction with consumptive hypocomplementemia. What will happen is that we know that this is the Bowman's capsule, these are the tubules, here is the glomerulus. So, whenever there will be any infection of the skin or throat due to group A streptococcal, it will produce, our body will produce antibodies against these antigens. So, there will be formation of antigen antibody complexes, and these antigen antibody complexes will go and deposit in our kidneys. in our kidneys. We know that the glomerular filtration barrier is made up of endothelial cells. Then there is the basement membrane, and then there are the podocytes. What will happen is that there is the subepithelial humps formation. When we see in the electron microscope, the antigen antibody complexes will come and they will start depositing in the subendothelial layer, and it will give appearance of a starry sky appearance or a lumpy bumpy appearance. It is granular. It will be not be continuous, not linear, but it will be granular. Means that some humps are present there, some are there, but it is not in a continuous fashion, it is in a granular pattern. So if we see, suppose this is the we see in the cross section, and then some depositors are there, some are here. It will giving a appearance of a starry sky and a lumpy bumpy granular appearance due to deposition of IgG, IgM and C3 deposition along the glomerular basement membrane and the mesenterium. What will happen is that when these complexes deposit in the kidney, it will start recruiting the WBCs and other army of the body that will come and fight against this um, antigen and antibody complex. So what will happen is that the when RBCs will come, there will be inflammation, there will be complement activation. Complement activation will cause hypo complementemia, because the complements will be consumed in this process, and the level of the complements like C3 will be less in the blood, because it will be deposited along the glomerular basement membrane and the mesenterium. So that's why their level will decrease in the blood. And in light microscopy, there will be enlarged and hypercellular glomeruli, because whenever there is infection, there is antigen deposition, the antibodies will come, there will be antigen antibody complex, immune complexes will deposit. It will there is a chemotactic factor C5a, which will attract the neutrophils. Their neutrophils and other white blood cells come and they will fight with the foreign agents. There will be use of complements. So there will be a lot of cells in this area, there will be lot of process going on this in this area. As a result, the glomeruli will become enlarged and they will become hypercellular. So what happens is that infection related glomerulonephritis, there is inflammation of the glomeruli due to any infection can be of skin, can be of throat, which will be due to group A streptococcus. When this infection will occur, it will cause antigen antibody complex, it will damage the kidney, and after 2 to 4 weeks the patient will present with signs and symptoms of nephritic syndrome. It is a type of type 3 hypersensitivity. There will be less number of complements remaining in the blood. The glomeruli will be enlarged and hypercellular immunofluorescence. We will see granular starry sky lumpy bumpy appearance due to IgG, IgM and C3 deposition along the basement membrane and the mesenterium. And in electron microscopy, we will see subepithelial immunocomplex humps. So that was all about infection related glomerulonephritis. Next comes the IgA nephropathy, which is also known as Bardet disease. In IgA nephropathy, what happens is that it occurs with the respiratory or GIT infections. IgA is secreted by the mucosal linings. Basically, IgA is an antibody that protects the mucosa of respiratory tract and GIT. So whenever there is infection of respiratory system or GIT, this antibody will come and it will fight against the antigens that are causing the infection. And what happens is that there will be IgA deposition in the mesenterium. Antigen antibody complexes will form, and these immune complexes will go into the kidneys and they will deposit in the mesenterium. We saw that mesenterium are the kind of support cells that are present in the kidneys. So these are the mesangial cells. We know that there is a mesangium matrix inside which there are the mesangial cells. IgA will come and deposit in the mesangium, and there will also be some damage to mesangial cells and mesangium, and eventually it will cause mesangial proliferation. So on light microscope, we will see mesangial proliferation. On immunofluorescence, there will be IgA-based immune complexes deposition in mesangium that is only specific to the IgA nephropathy. And in electron microscopy, there will be mesangium immunocomplex deposition. So what happened is that there is respiratory or GIT infection, and then the IgA will come and protect the GIT respiratory tract. There will be formation of immunocomplexes that will deposit in the mesangium. There will be mesangial proliferation. I see complexes in the mesangium that are IgA based, and the mesangial are immunocomplex deposition in the electron microscope. So it is only the mesangial involvement we will see in the IgA nephropathy. Next comes the Alport syndrome. In Alport syndrome, there is also clinical presentation of nephritic syndrome. You know that glomerular basement membrane is made up of type 4 collagen. If there is mutation of type 4 collagen, it will result in the Alport syndrome. So it will affect the basement membrane of the eyes, ears, and the kidneys. Eyes, ears, and the kidneys. So resultingly, when there is mutation in collagen, it will cause glomerular basement membrane alteration, and it will cause eye problems like retinopathy and anterior lenticonus, in kidney problems like glomerulonephritis, and ear problems, sensory neural hearing loss, can't see p, can't hear, can't see p and hear, and it is a X-linked dominant disorder. In when we will take a biopsy of the kidney and we will see it under the light microscope, we will see irregular thinning and thickening and splitting of the glomerular basement membrane. This basement membrane is made up of the collagen. When there is mutation in the collagen, somewhere there is thinning, somewhere there is thickening, and it will give the appearance of a basket weave. We will see under electron microscope a basket weave appearance due to irregular thickening and splitting of the basement membrane. And since there is no deposition of immune complexes in immunofluorescence, it is initially negative and there is non-specific staining. Usually it stays negative. Next comes the rapidly progressing glomerulonephritis. As the name suggests, there is inflammation of the glomeruli, and rapidly and progressive means there will be loss of the kidney function within weeks to months. It is very rapid. And the second one is the crescent. What happens is that there will be formation of crescents. These cells will arrange in the form of crescents. That is why it is known as crescenteric. There is very poor prognosis, and there are multiple causes. And type 2 hypersensitivity reaction is involved in Goodpasture syndrome. If we see how the crescent moon shape is formed, the crescent, it is important that a crescent is consisting of fibrin, plasma proteins, for example C3b, with granular glomerular parietal cell, monocyte, and macrophages. So crescents are formed by cells plus the plasma proteins plus the fibrin. It occurs like that. The cells come and they deposit, and upon the cell there is a deposition of fibrin, and collectively it appears in the form of a crescent. It eventually narrow the lumen of the capillaries. So it is known as rapidly progressive crescenteric glomerulonephritis. If we will see in under the immunofluorescence, we will see three patterns. There is a linear pattern, there is a negative immunofluorescence, and the third one is the granular pattern. If the antigen antibody complexes are arranged in a linear pattern, it is known as linear immunofluorescence. If they are arranged in granular patterns, some deposits are here, some are here in the form of granules, this pattern is granular. And if there is no deposition of any immune complexes, it is known as quasi-immune or negative immunofluorescence. First of all, in linear immunofluorescence, it is seen in Goodpasture syndrome. In Goodpasture syndrome, antibodies are formed against glomerular basement membrane and alveolar basement membrane. So there is involvement of lungs plus kidneys in the good pasture syndrome. The antibodies are produced along against the whole glomerular basement membrane, and there we will see a linear pattern of immunofluorescence. And in good pasture syndrome, we will see hematuria because of blood in urine, and hemoptysis because there is also involvement of lungs. In granular pattern, we have also studied the example of post-streptococcal glomerulonephritis, in which we saw there was enlarged hypercellular glomeruli related to infection, and on immunofluorescence we saw a granular pattern. But when it progresses, it will take the shape of the rapidly progressive precenteric glomerular nephritis of granular pattern. The third one is the negative, that is known as post-immune. In post-immune crescentic glomerulonephritis, there is lack of detectable anti-GBM antibodies or any immune complexes by immunofluorescence and the electron microscopy. Most patients with this type have circulating anti-neutrophilic cytoplasmic antibodies that produce a cytoplasmic or a perinuclear pattern, cytoplasmic or a perinuclear pattern. So more than 90% of the idiopathic cases have CNCAs, means cytoplasmic anti-neutrophilic cytoplasmic antibodies, now called as PR3-NCA, because the antibodies are specific for neutrophil granule protein proteinase 3, or PNCA. Now they are called as MPO NCA, indicating the reactivity with neutrophil myeloperoxidase in the serum. If we see under the electron microscope in good pasture syndrome, we will see break in the basement membrane, necrosis, crescent formation with no deposit. In post-immune, there are no deposits, and electron microscope features depend on the underlying causes. Basically, there are three types: linear, granular, and post-immune. If we see their examples, linear immunofluorescence, the example of good pasture syndrome, and it is renal limited. And in immune complex immune complex deposition pattern, there is post-infectious or post-streptococcal glomerulonephritis. And in post-immune, there are ANCA-associated diseases like uh, granulomatous polyangiitis, formerly known as vaginal granulomatosis, and microscopic polyangiitis. Next comes the membranoproliferative glomerulonephritis. There are two types, type 1 and type 2. Type 1 may be secondary to hepatitis B or C, and type 2 is associated with C3 nephritic factor. IgG autoantibodies that stabilize C3 convertase. There is persistent complement activation and decrease in C3. Basically, the type 1 is secondary due to the infections, and type 2 is associated with the C3 glomerulopathies, and it is also known as the dense deposit disease. In type 1, there is deposition in subendothelial immune complex deposit, and in type 2, there are intramembranous deposits. Here they are showing the different kind of deposit. These are the mesangial deposit, these are the subendothelial, intramembranous, and the subepithelial. So in type 1, there will be subendothelial deposition, and in type 2, there will be intramembranous deposition. What will happen is that this is the basement membrane, and in this type, there will be splitting or doubling, you can say double contour of the basement membrane. Granular basement membrane is thickened, and it often shows a double contour or tram track appearance that is evident in silver or PAS stains caused by the duplication of the basement membrane, commonly referred to as splitting. So what happens is that this is basement membrane, here is the deposition of the immune complexes, and it will give the appearance of a double membrane or a splitting of the basement membrane. And it is also, we will see on HNE and PS stains, it will be giving a tram track appearance or a glomerular basement membrane splitting. And there will also be mesangial ingrowth, and due to immune complexes deposition, there will be granular pattern on the immunofluorescence. Last one is the diffuse proliferative glomerulonephritis. It is associated with SLE, associated with the lupus nephritis, and diffuse proliferative glomerulonephritis and membranoproliferative glomerulonephritis often present as nephritic and nephrotic syndrome concurrently. And in electron microscope, we can see subendothelial and sometimes subepithelial or intramembranous deposits. In IF, we will see granular pattern, and in light microscopy, we will see wire looping of the capillaries. The capillaries will become thickened, and it will give the appearance of a wire looping. So that was all about nephritic syndrome and its associated examples. And in nephritic syndrome, there is severe glomerular basement membrane damage, which will lead to RBC in the urine plus impaired charge barrier. It will lead to hematuria plus proteinuria, nephrotic range proteinuria more than 3.5 gram per day, and concomitant features of nephritic syndrome. And it can occur in any form of the nephritic syndrome, but it is more common with diffuse proliferative and membranoproliferative glomerulonephritis.